air. The upper respiratory passageways have, as you recall, a mucosa that's laden with a sort of lubricious, mucousy, mucopolysaccharide coating that helps to trap particulates, prevent particulates from aggregating into the deeper passageways. You have cilia, hairs in the upper respiratory system that contribute to that. Typically, they impede the movement of the particles. The particles are then taken into the mucosa where they can be metabolized. You also are familiar with the mucus escalator. Those particles that do get into the deeper parenchyma can then be taken up by ciliary action via the proximal bronchi and trachea. The upper respiratory passageways are also important for humidification of the air. This prevents desiccation of the upper respiratory epithelium, but also it's important to keep in mind that, of course, when the oxygen is taken into the blood, it has to go into solution. And in reality, the gas molecules are taken into solution in the membrane or at the membrane of the alveolus. So this process of partially solubilizing, I'm having trouble talking today, solubilizing the gas into solution is facilitated by the upper respiratory passageways. And then this last point has to do with a number of laws you perhaps remember from basic chemistry, Henry's law, Charles' law. There are a number of physical factors that affect the ability of gases to go into solution. And by going into solution, we mean dissolving into water or dissolving into blood. And you probably remember that, for example, partial pressure, the relative availability, the relative abundance of the gas above the fluid is going to be important. But another factor is temperature. And it's important, of course, I guess the way to think about this is that typically your body is going to be 98.6 or around 37 degrees Celsius, and that the outside temperature is not going to be that in many cases. It's usually going to be colder. It could be warm in Florida, I guess. But that means there's a disequilibrium, there's an imbalance between the temperature. And if it's true that temperature affects the ability of gases to go into solution, and vice versa, by the way, the pre-warming is important in optimizing the uptake of gas into the blood, which is occurring in the pulmonary capillaries. One silly example I sometimes use is let's imagine a polar human. And by polar human, I mean a human that lives at the North or South Pole. And one of their peculiar adaptations is their lungs are on the outside of their body. So we imagine this hypothetical alien-type creature who lives at the North or South Pole with their lungs outside their body. By the way, there's some salamanders and other amphibians with this type of anatomy. They have more gills than lungs. So what would be the problem? What would be the problem with their particular anatomical arrangement? The blood in the lungs, let's say, would be very, very cold. We won't need to worry about the temperature. But the body temperature of these hypothetical individuals would nevertheless be normal, let's say 98.6 degrees. So as we think about that, maybe I should proceed as you contemplate this creature and the problems they're going to have breathing. Let's talk a little bit about the relative solubility of gases with respect to temperature. Does a warm or hot gas, does a warm or cold gas, I'll wake up in a moment. Does a warm or cold gas, I'm just taking away my Fabio back. Does a warm or cold gas hold more water? Does a warm or cold gas hold more water?
Warm.
All right. Everybody agree that a warm gas holds more water than a cold gas? What about a fluid? Does a warm or cold fluid hold more gas? Cold. All right. So you can see it's the opposite. All right. So let's go back to our example. If we're all in agreement on that, that's surprising. But if we all are in agreement about that, let's go back to our hypothetical polar human with the lungs outside the body, breathing the very, very frigid air. So you've indicated that the air that they're taking in is going to be very cold, and you've indicated that air, the gas, is not going to solubilize very much water. All right. They then, and of course that's then going to be taken into the blood in those lungs. The blood is going to be very cold too out there in the pulmonary capillaries that are outside of their body. And then that blood that's taken up the gas is going to move into their body, which is 37 degrees, 98.6 degrees Fahrenheit. What's going to happen when that blood that now comes from a very cold region now goes into the body? What's going to happen to the gas that's dissolved in that solution?
Goes out, goes
It's
away.
going to come out of solution. So you can imagine, as a consequence, that little bubbles would form, and those in effect would be little emboli that could block capillaries. This is analogous to what happens in the bends, for example, or diver's narcosis or something like that. So it's a silly example, highly exaggerated. But the point is that this pre-warming optimizes or facilitates the solubilization of the gas into the blood, and ensuring that there's maximal transfer, maximal uptake in the lung. So all three processes are very important. But there's a little statement here about airflow relationship, but what I'm going to do is just go right to this diagram and make sure we understand the importance of this illustration, especially with regard to our discussion of cardiovascular physiology. Now, at the top here in the illustration, we have the anatomy as we've talked about it. You can see conducting airways and the respiratory airways over on the right. You have references to the generations. You know there are about 20 to 25 generations, and that refers to the brachiation or divisions of the airways into branches. And we actually have some of the terminology to describe that relationship here. So there's a nice review of the anatomy in the top illustration. By the way, and I don't know if we mentioned this, I think we may have, but we're going to assume that the volume of the conducting airways is about 150 mils. And we're going to assume that the volume of air that you breathe in and out, this is going to vary with a lot of circumstances, but as you sit there right now, the volume of air that you're breathing in and breathing out, we're going to call that tidal volume, is about a half liter. It's about 500 mils. So maybe make a note of that. So you can see the relationship of the conducting zone to the tidal volumes, much less than a third or so. Now, in the graphs at the bottom of our illustration, we have these terms, which we described before, we've used before with respect to our discussion of cardiovascular flow, pressure, and velocity. So the red line is total airway cross-sectional area, and the blue line is individual airway diameter. So make sure we acknowledge the difference. So basically, it's just the blue line is arguing that as we move in this direction, the airways are going to become progressively smaller, become smaller in diameter. But the red line, on the other hand, is suggesting what? Somebody explain why the red line is going up.
As the total area is increasing.
All right, the total or the aggregate, the composite area, the collective cross-sectional area of all of these little airways that you see here is actually increasing. Each one is smaller, but because there's so many of them, again, we're combining straws. Each one of them is so small, but as we combine them, the aggregate area increases. Now, in the respiratory system, we do have a bit of a complication to the extent that there's a little hiccup right here. And we won't worry too much about this, but you'll notice that initially, as we go, for example, to the trachea, the primary bronchi, collective airway diameter actually decreases. Just for simplicity, just to make sure we're all on the same page, let's say this continues until about the third or fourth generation. That decrease in the collective airway size decreases till about the third or fourth generation. Again, we're being very conservative here. But then after that point, as you can see, there's a fairly linear resurgence. Now let's correlate that to what is shown over here on the right illustration. So we have two lines here. One is velocity, one is resistance. The sort of yellow or butterscotch line there is resistance. The green is velocity. So As aggregate cross-sectional area increases, what happens to resistance? Decreases. So there's an inverse relationship between, as we saw with cardiovascular physiology, inverse relationship between aggregate cross-sectional area and airway resistance. So again, make sure you understand what we're saying here. As we move in this direction, the resistance to the flow of air decreases. Conversely, and this is probably more important for you because this is where you're going to be spending a lot of your time dealing with the problems of your patients. Where is airway resistance greatest in most cases? Proximally in the upper airways, especially in the primary bronchi and so on, or even in the trachea conditions such as asthma. Now, the other thing to pay attention to, if that's true, they're calling this mass flow here, but really it's the same as speed or velocity. What happens to the velocity of airflow as we move deeper and deeper into the lungs? The speed decreases. All right, now think about the physiology of that. Does that make sense? We're getting deeper and deeper, excuse me, into the alveoli. We already know that blood flow is decreasing because the vascular, the distribution of blood vessels follows somewhat the same pattern. So does it make sense to you that both airspeed and blood flow, blood velocity, tend to decrease as we move deeper and deeper into the lungs toward those alveoli? What would be the function of that? What would be the benefit of that?
You got to slow it down for sufficient gas exchange.
Exactly. Optimization or maximization of gas exchange. We'll come back to that a little later. But it all works out. It's, again, the problem you're going to have, well, you can have a problem there too, and diseases, alveolar diseases, pneumonia, and that sort of issue. But again, a lot of the issues you're going to have are with the resistance presented by this proximal system up here. Yeah. Well, again, this mass flow just refers to velocity. It's just another term for speed in this case. Flow, as we defined it in the cardiovascular unit, would not be related to velocity. So I agree with you. This is not the best use of terms, but this is what they mean by that. I wish I could tell you that in all cases terms are used in a equivalent fashion in all sources, but that's not the case. All right, so with that introduction, let's talk a little bit about ventilation. And ventilation is the formal term to describe breathing. And by breathing, we're talking about the movement of air into and out of the thoracic cavity. Now, breathing is analogous, or I should say the muscles that power ventilation, the muscles that make ventilation possible, are analogous to the heart, to the extent that the function of these muscles, and you're looking at the main one over here on the right, their function is to generate the pressure difference, generate the pressure gradient necessary, as apropos Evan's question, for flow to occur. Remember, for any type of flow, you have to have a pressure difference. So these respiratory muscles are generating the pressure gradient necessary for airflow to occur into and out of the lungs. It's got to be a little bit qualified there, because as it turns out, in normal resting breathing, only inhalation is active. That is to say, only inhalation needs that pressure generator turned on. Exhalation, at least as you're sitting there now, is passive and is achieved by something we'll call elastic recoil. So the primary muscle of respiration, the primary muscle of ventilation, to be more accurate, is the diaphragm. And we'll look a little bit at how it's working there. I can see my little animation is not working for some reason. But the diaphragm is the primary muscle of respiration. Remember, it has a very curious anatomy. It's attached more or less there at the base of the rib cage, but it arches into the thoracic cavity. And when it contracts, and you can see this is sort of the relaxed diaphragm in situ there relative to the lung. But remember, for a variety of reasons we'll talk about in a moment, the lung is going to assume whatever conformation the diaphragm takes. But when the diaphragm contracts, it tends to flatten somewhat. It tends to flatten a bit. And that has two effects. Primary effects, let's see if my other animation is working here. Yeah, you can kind of see it here, although this isn't entirely realistic. The two primary effects of the contraction of the diaphragm are to expand the base of the thoracic cavity, making it wider, and as you can see in the animation, to elevate the ribs. Elevation of the ribs is sometimes called the bucket handle effect, but the ribs are going up and out. Now, the net effect of that, the consequence of that movement, is to increase the volume of the thoracic cavity. So the exclusive, the entire, the only function of the diaphragm, and as we're looking at it here, is to increase the volume of the thoracic cavity, and it's that volumetric increase that is responsible for inhalation, again, at least in normal resting breathing. So as we've indicated, resting inhalation is active, involving primarily the diaphragm. Resting exhalation is passive. It's achieved by really two components. These are sometimes called elastic series components. The two components that sort of power exhalation, and it does take energy, it does take force to expel the air, are the elasticity of the thoracic wall, but even more importantly, the elasticity of the parenchymal lung tissue, and we'll talk more about that later. The lung tissue in many respects is like a bunch of rubber bands pulling on the thoracic wall. We've got to explain the magic of that. So once that thoracic wall is expanded, as we saw in the animation, the lungs, acting like rubber bands, and simplifying it, we're going to want to pull it back. So if you're sitting there right now, all you have to do is breathe in, expand the thoracic cavity, the air goes in for reasons we'll talk about in just a moment, and then passive exhalation. Now, in active respiration, which you would be engaged in when you're talking, singing, running, when you're involved in strenuous physical exercise, or when you're trying to overcome a physiological load, as if you're lying on the floor and somebody is standing on your chest. All right, those would all be examples of requiring active respiration. A large number of other muscles may be recruited, and these are muscles of the thoracic wall, for example, and you're familiar with all of these, the sternocleidomastoid, the scalene, the serratus muscle, potentially the pectoralis, even perhaps some intrinsic back muscles. All of these might be utilized to enhance volumetric increase, and in active respiration to actively expel. In fact, you're going to be giving your patients spirometric tests, something you learn about extensively before you leave here. A little device you'll give the patient about the size of the fist. You'll ask them to inhale and exhale at least once, perhaps several times, and you'll record the dynamics of the volume of air as it comes in and as it leaves their thoracic cavity. Again, it's a spirometer that achieves that, but when the patient is engaged in those spirometric analyses, they're recruiting these active muscles of respiration. Now, there's a sort of intermediate type of muscle we talked about in the anatomy called the intercostals. Of course, you're familiar now with the three layers of intercostals, the external, internal, and then the innermost intercostals. Here we can see the external intercostals, the internal, and at least at this point in the rib cage, thoracic rib cage, you can see the difference in the trajectory. So I'm a little hesitant to get into this, but let's just sort of summarize it in the following way. That for the most part, the external intercostals contribute to inhalation. Because if you think about standing up here, you can see the art. Standing up here, throwing a rope down to the bottom of this rib and pulling up, you can pull the rib up and out, which we said is important in inhalation. And conversely, to the extent that this general principle is true, the internal intercostals contribute to active exhalation or expiration. Part of our problem in a good portion of respiratory physiology is where I could speak authoritatively on these topics even 5 or 10 years ago, the science has changed, and these are all based on animal models that don't seem to be holding up all that well. But in any case, let's just say that these intercostals may or may not be involved in passive breathing, but to the extent that they are, the externals are primarily important for inhalation. The internals are important for exhalation. Again, remember the anatomy. These turn into membranes, both posteriorly and anteriorly. So, in this little animation, let's see if it starts. Of course not. And this is an important animation. Of course, I tested it before I came today, and it's working fine. But there's something about that fellow standing in the back of the classroom that's probably. Give me just a second. If necessary, I'll bring this up on the device. All right, here we go. Sometimes the problem is getting the resolution to the projector. All right, so what's the simulation here? We have a bell jar, a large bell jar. We have two balloons attached to little tubes going through the top of the bell jar. And then this membrane down here is intended to represent what?
Diaphragm.
The diaphragm. So you can see, of course, the problem here is that when the person is depressing or pulling down on that diaphragm, the volume of the thoracic cavity is increasing. So with that dissimilarity, everything else is comparable. But notice, as the thoracic volume, as the volume of the bell jar increases, the lungs inflate. Why? All right, so you're right. So of course, there's a increase in pressure corresponding to a increase in volume corresponding to a decrease in pressure. What do we call that? What's the principle? That's Boyle's law. All right, so to understand breathing, to understand simple ventilation, you only need to know two things. Number one, this principle that I've articulated about 75 times since the beginning of the course, everything flows from high to low. Everything flows from high pressure to low pressure. Right? You need some type of pump to generate that pressure gradient, but that's number one. So when you breathe, if air is moving through your nose or your mouth in one direction or another, it's in response to a pressure gradient, pressure difference. Now, the other thing you need to know about breathing is simply Boyle's law, that there is an inverse relationship between pressure and volume. So as we increase the volume, the pressure drops. And if the pressure inside the thoracic cavity decreases relative to the out here, which way is the air going to move? In or out? In. Is that clear? Simple. So those two principles, I think this is really all you need to know, and I think that's pretty much indicated by the little video here. All right, here's a little animation that is helping us understand the relationship between some of these critical pressures. Again, this is a significant simplification, but I would have you understand that there are three primary pressures that need to be kept in mind here. First of all, there's going to be barometric pressure or atmospheric pressure. So these two pressures are going to be changing during the ventilatory cycle with respect to atmospheric or barometric pressure. And you can see barometric pressure is just arbitrarily zero. It's in reality about 760 millimeters of mercury or 1 atmosphere, let's say at sea level. Then they're calling this other pressure, this arrow here, alveolar pressure. All of these go by different names. In your medical literature, you're going to see alveolar pressure also called pulmonary or intrapulmonary pressure or intramural pressure. And then this one here is one we need to talk about more in just a moment, but it's intrapleural. Remember in the thoracic cavity surrounding the lungs, you have two pulmonary compartments, and those compartments are enveloped by the parietal and the visceral pleural membranes. The intrapleural pressure is the pressure between the visceral and the parietal pleural membranes. Now, as we look at the little animation, I want you to pay attention to the relationship between these three pressures. I'm not sure I have the digital dexterity to achieve this. There we go. So notice at the top there, it's called inspiration. That's what every day in this class is all about. So there's inspiration. All right. Now, as we move from left to right, and we're moving toward inspiration, what happens to alveolar pressure? Do it again. It decreases. All right. So the pressure inside the lungs during inspiration drops relative to barometric pressure. And as we go over here to expiration or exhalation, what happens to the alveolar pressure?
Increases.
It's above atmospheric pressure. And once again, airflow is simply going to go from high pressure to low pressure. So in the exhalation phase, because alveolar pressure, the pressure of the air inside the lungs is greater than barometric pressure, the air is going to flow out. Simple as that. Now, the pressure, what did you notice about intrapleural pressure? I'm not so much interested in the relative movements right now, but in general, what is the relationship of intrapleural pressure to both barometric pressure and alveolar pressure during the entire ventilatory cycle? It's always lower, and it must be lower than either of the other two. The intrapleural pressure must be lower. In fact, if intrapleural pressure reaches atmospheric pressure, your patient can no longer breathe. It's not breathe efficiently. And we need to talk more about that and why that occurs. Are there any questions about the relationship between these three pressures and what they refer to? You can watch the cigarette smoke go into the individual's lungs here. But, by the way, notice the abbreviations here. PB, peak pressure. We're going to talk about these partial pressures later in pressure designation symbology. Barometric pressure, alveolar pressure, and then intrapleural pressure.
Respiratory muscles change.
Let me find the volume so low here.
The volume of the lungs by changing the volume of the thoracic cavity. The major inspiratory muscles are the diaphragm and the external intercostal muscles. These muscles contract during every inspiration to enlarge the thoracic cavity, with the lungs following along. The intra-alveolar pressure within the alveoli, or air sacs, is 760 millimeters of mercury when equilibrated with atmospheric pressure. Lung expansion reduces the intra-alveolar pressure below atmospheric pressure. Air flows in during inspiration until intra-alveolar pressure equilibrates with atmospheric pressure. The accessory inspiratory muscles, located in the neck, contract only during more forceful inspiration to further enlarge the thoracic cavity. As the lungs further expand to fill the larger thoracic cavity, the
Notice there's
intra-alveolar
not
pressure
much of a
drops
difference here.
further below atmospheric pressure, so that more air flows in before equilibration occurs. No muscles contract to accomplish expiration during quiet breathing. During quiet, passive expiration, the inspiratory muscles relax and the thoracic cavity and lungs return to their pre-inspiratory size. As the lung...
So you get the idea, but what I wanted you to pay attention to is just a very small pressure gradient between inhalation and exhalation. The other thing I wanted to mention too, let me see if it's probably not. As we look at this, as we look at that animation again. Let's just watch it cycle there. There are 2 points in the, and watch it carefully, there are arguably 2 points in the ventilatory cycle at which alveolar pressure is equivalent to atmospheric pressure. how would you describe, and arguably they're the same thing, but how would you describe those? At what point, looking at that animation, is alveolar pressure equivalent to atmospheric pressure? Can somebody do it? Can somebody perform this amazing feat of equalizing alveolar pressure with barometric pressure? You must be doing it each time you breathe. So when are you doing it? At the conclusion of your inhalation and at the conclusion of your expiration. I can't actually inhale and expire without passing out. But you get the idea. According to the animation, I'm kind of like Fabio back there. I don't do a lot of breathing these days. Is that clear? So, notwithstanding some unusual circumstances, as you can see in the illustration, the animation here, if we go back, at this point, atmospheric pressure is equal to alveolar pressure, and at the conclusion of the cycle, atmospheric pressure is equal to alveolar pressure. And whether you wish to call them the same or not, but it's basically the conclusion of inhalation and the conclusion of exhalation. All right. So we need to talk a little bit about this intrapleural pressure. Remember the parietal pleural, the parietal membrane covers the wall of the thoracic cavity, the visceral membrane lines the exterior of the lungs, and then between those two we talked about the reflections, the costodiaphragmatic recesses, and so on. But that little intervening space, generally a potential space, is called the pleural space. And it's important to realize that in most cases that is only a potential space. If that space becomes patent, becomes open, if there's actually a physical separation of those two membranes, that's going to present respiratory problems for your patient. Now, let's talk a little bit about why that is the case. So what we're saying is that, and this is exaggerated, of course, but that one of those little blue lines is the visceral membrane, and the other one is the parietal membrane, and they're normally stuck together. They're normally glued together. I use that word figuratively, but in fact, they're pretty much glued together. And they're glued together despite antagonistic forces that would draw them apart. At any given time, especially when you're breathing in or breathing out, but really it's true. Remember when we looked at that animation, intrapleural pressure was always lower than barometric pressure and alveolar pressure. Here's alveolar pressure. Here's barometric pressure out here. So the pressure in here is always lower. So how do these two membranes stay glued together? Anybody have a theory on that?
Cohesion of the serous fluid.
Well, it'd be a little more specific. You're saying that you're just telling me that the fluid is acting as a glue?
Yeah, the cohesion property of the fluid.
All right. Smith?
Because the pressure is higher inside is pushing out, the pressure is from the outside is pushing in.
I think you're both right. I think you're both exactly right. But let's put some meat on that so everybody can understand what you're saying. So, David, you're saying that this is a glue. Can you give me any chemical properties that would use it's serous fluid? If I took some serous fluid, I would just threw it down the table here, I'll bet I could put my finger on it and it wouldn't be sticky at all. So what are we talking about here that's responsible for this adhesion? All right, so, and what's we didn't talk about it in this class. All right, surface tension, that's a little more meat. So what is in your chemistry class, what did you learn is responsible for all those wonderful properties of water, such as surface tension? Hydrogen bonding, all right. That intermolecular adhesion between the molecules of water. So we have this adhesion, that's why when we take the drop of water and put it on a smooth surface here, it beads up. But the better analogy would be, because of that intermolecular adhesion pulling those molecules together, the polarity of the hydrogen and the oxygen, the positive hydrogen, the negative oxygen, and so on. A better example might be relating to what Samantha was talking about. When we put these two together, let's imagine you were looking through the microscope back in biology class. You may have done it more recently, but you remember they always gave you the slide. You put the pond water or some inky biological preparation on the slide, and then you'd always do what before you put it under the microscope?
Cover
You
it.
put the cover slip on, all right? And as you recall, if you try to pull that cover slip off,
So,
it'll break. Just pull it right off. How did you normally remove it? You had to slide it off. Like analogous to putting a mirror on a glass vanity top or something where there's water there. So again, what's responsible? What is responsible for the tenacity between the the cover slip and the microscope slide? Well, the hydrogen bonding is only part of that. Again, as mentioned a moment ago, there's something else in there. For example, why does it come off so easily if I just begin sliding it and then separating it at that point? What's pushing those two things together? Not gravity, atmospheric pressure is basically, because what you have in effect between those 2 points is a vacuum. And only when you introduce air at that point is that vacuum removed. So 2 things happening here. We have the intermolecular adhesion caused or associated with the hydrogen bonding of this aqueous fluid. But you also have, and this is going to be important because you have these other forces, you also have, in effect, a vacuum in here. And so imagine what would happen if we remove that vacuum, if we crack the cover slip and we allow air to get into that space between the slide and the cover slip, it comes right up. What would happen to this adhesion between these 2 blue lines if I put a knife in here, puncture this, and allow air to get in? Is that adhesion, is that glue-like quality going to remain? No. So we'll talk about that in just a moment. So is that clear? Is it clear? Number one, just make sure you understand that there is a very robust physical adhesion between the visceral and the parietal pleural membranes, caused in part by the intermolecular properties of the pleural fluid, but also by the dynamics of the air pressure. We'll try to expand upon that a little bit as we continue. Now, in this system that we're looking at here, remember we said that intrapleural pressure is always lower than barometric pressure or alveolar pressure. I had a syringe. I always use a syringe to illustrate this principle. That a nursing student brought her child into my office recently, and the child made off. She pilfered my syringe, so I no longer have a syringe. I hope she's happy with my syringe. But if I take a syringe and I put my finger over the end and I depress the plunger, the air pressure in that syringe will go up or down. Pressing, my fingers are out, pressing on the plunger. Does it go up or down?
up.
Up. All right. Same thing, now I'm going to pull on the plunger. The pressure inside that syringe goes up or down? Down. Is that all right? So everybody understands, very simple relationship. As, again, Boyle's law again, as I increase the volume, the pressure goes down. As I decrease the volume, the pressure goes up. All right. Now, here, and the other part of this complicates our story because this is fluid, right? And fluid does not obey Boyle's law. We have fought this battle in our isovolumic relaxation and contraction phase of the cardiac cycle. But can the pressure change? Does the pressure in this, between these 2 membranes change as I pull apart the plunger and the body of the syringe? Yes. So here's what I want you to understand. That even though this Boyle's law, we don't have a change in volume here, the pressure drops because of 2 forces. The elasticity of the thoracic wall pulling one direction and the elasticity of the pulmonary tissue pulling the other direction. So despite that antagonism, these 2 membranes nevertheless should remain very tightly apposed and glued together. But in any case, that accounts for the very low intrapleural pressure throughout the ventilatory cycle, even as the alveolar pressure, the intrapulmonary pressure, goes below barometric pressure and goes above barometric pressure. Intrapleural pressure changes, but it never exceeds either of the other 2. So in this slide, I've simply summarized all of the points we've been talking about because I don't think it's true for you folks. You seem to be picking up on this quite easily. But this is simply a summary of the principles governing the flow of our air. This is all you need really to know and understand ventilation. And then we've talked about the muscles that power ventilation, chiefly the diaphragm, and of course, in order for the lungs to comply with the changes in the volume of the diaphragm, then the lungs, the wall of the lungs, must be effectively glued to the wall of the thoracic cavity. So that when the thoracic cavity changes volume, the lungs do what? They comply. We've used that word before. The lungs are very compliant. They're also elastic, and that elasticity is responsible for passive exhalation. Now, I asked you a moment ago what would happen if either from this side, either from inside the lungs, this is something as a PA you're going to have to contend with. You're going to have elderly patients who fall, or it could just be spontaneous. Sometimes you don't know. Sometimes it can be secondary to some other pathology. But my point is, there can be a breach of that pleural space. There can be a defect that occurs either from the outside across the thoracic wall or from the lungs into the pleural space. In either case, what's going to happen to the pleural pressure, the intrapleural pressure, if there's a breach in either direction? Is it going to go up or down? Up. It'll always go up. And when that happens, you can think of the microscope slide on the cover slip on the microscope slide. When that happens, there will be effectively no glue. There's no adhesion between the lung and the thoracic wall, and to that extent, then the lung will tend to collapse. Effectively, collapse lung. So that's what we call a pneumothorax. A pneumothorax is simply a decrease in the volume of lung as the wall of the lung is no longer adherent to the thoracic wall. And again, that can result from a puncture wound externally or from a rib fracture. Right? The patient falls, the rib breaks, and that could also cause a breach in the pleural space from the inside. Now, a tension pneumothorax occurs. In fact, I have a little video. So I found this one. I've edited this heavily. If anybody wants to watch the full video, I can give you the link. But he seems to be a very recent medical student, or just recent graduate, and he's describing his excitement when he corrects for this. This is the high point of his day in the emergency room. But let's see if you can. And I think he talks about. I don't know what I edited out. Let's see if he talks about the tension pneumothorax.
Here we're actually going to talk about one of the coolest procedures in emergency medicine, which is chest tube placement. Essentially, it's putting a tube in.
Hold on a second. I want to see if I can get this volume up. All right.
Into the chest. So here we're actually going to talk about one of the coolest procedures in emergency medicine, which is chest tube placement. Essentially, it's putting a tube into the chest, as the name says. And it's one of the coolest things because it's one of the few times where you have to do it. It could potentially be life-threatening if you don't do it quickly enough. Number 3, you have permission to stab a patient, to open their chest, kind of put your finger through the muscle layers into the chest wall, into the chest cavity, and then put a chest tube in. The important thing about the anatomy, and I'm going to show you the pictures here from the netter, is what is called the anterior axillary line, the mid-axillary line, and the posterior axillary line. And that refers to the axilla and the side here where you're going to do it. You're going to do it at the height of the nipple. So you look at the patient's nipple, and right there, that's the site where you're going to do this. Now, sometimes doctors deviate from this because they want to drain not air like a pneumothorax, but they want to drain blood, and they want the chest tube to be pointing down. Or they want to empty an empyema, which is pus within the chest cavity. So they want to target it and go a little bit lower. But the danger is you got the diaphragm, which starts up here but curves like this. So if you go kind of low, you can go in through the diaphragm and into the abdominal wall, which has happened if you get it on the right spot. So nipple line, anterior mid-axillary line,
I said stop. And in the actual video, he talks about that actually happening. He talks about one of his superiors growing impatient with his reluctance to find the right spot, taking a tube, pushing it through the diaphragm into the spleen. And the man lost the spleen. So you have to be careful. You have to be familiar with the anatomy. But before we continue this, I know we'll take a break at the conclusion of this. So this is a procedure for putting a chest tube in. And I thought I'd left the portion about the pneumothorax, and I guess I didn't. But let's say there is a puncture wound. Your patient has a puncture wound of some type. There is an external breach. There's some jagged wound there. And the lung is collapsing. So the patient is going to be doing what? How is the patient going to be compensating for this collapsed lung? Gasping, yeah, breathing more actively. All right. Now, as that happens, that increases the pressure difference across the thoracic wall. And with each gasp, the air is going to go in much more rapidly than it comes out, if it comes out at all. There's all kind of blood and mucus and all sorts of stuff here that prevents the blood or prevents the air from escaping. So with each gasp, that lung gets smaller and smaller, but that volume between the lung, or the volume between the mediastinum and the thoracic wall, is getting larger because the air is getting sucked in here and it can't get out. All right. So with each gasp, that volume increases. Eventually, it presses on the mediastinum. It compresses the heart. The heart's in peril. Of course, it's also going to compress the other side. That's a tension pneumothorax. Tension pneumothorax is not simply a breach, but with each increasing inhalation, there's further compression of the heart, the mediastinum, and the other lung. So, how do you correct that? We've got this significant elevated pressure on one side of the thoracic cavity. How are you going to correct that? What would be your first instinct? What do they do on all the television shows? Yeah, they find a ballpoint pen. But no, it's not so much a needle. Do you use needles? Because the needle is not the approved procedure in the United States, but I know they do this in Europe and elsewhere. Which in general, you're right. You want to relieve that pressure. You want to get that pressure back to normal. So that's what he's talking about here. And as I said, we'll take a break. I think it's about 3 minutes.
So you dissect through until you feel your rib space. Now you want to go right above the rib. And if you look at this picture from Netter, the neurovascular bundle, the artery, the nerve, the vein, the nerve and the vein are underneath the rib. So if you go and put your chest up right underneath that rib, you can nick the artery and it causes severe bleeding. You can nick the nerve and cause some peripheral neuropathy, some damage to that nerve. So you don't want to do that. You want to go right above the rib. So once you get into that space, there are different kits. So some of them have a trocar, which means a big, hard metal wire, which you use to actually stab the patient with it. Remove the guide wire, and then you're already in.
Don't use that.
So you use the tube itself to push through, basically stabbing the patient. Now, the older methods were the blunt dissection. You take forceps and you dissect the muscle layer, start pushing, and then you use it to pop the space, open it up with your forceps, and then keeping that space open, you keep your finger in to save that hole. You don't want to lose the spot you just made a hole. And then you take your chest tube, and then you push it through into the cavity of the chest wall. As I'm showing in this video right here, we're using the trocar method, and the doctor's trying to push that in. Now, it does require a fair amount of strength. You're actually stabbing through muscle layers into the chest cavity wall. But you have to do it right. You have to push hard and get in. And if it's for pneumo, you should hear a pop and a whoosh, like opening a soda bottle, because the air is escaping. There should be plenty of condensation into that chest tube as you're doing this, signifying that it's in the chest wall cavity. But the most important thing about this is make sure you're in position. The last thing you want to do is think that you're in. Go ahead and close the skin layers, tie the tube to the chest wall, go and get an x-ray, and then find out you're not even to the chest cavity. You're actually in the muscle layers and you left the tube there. It's not doing anything.
Then he talks about going and talking with the family, saying, well, yeah, we've got to take your loved one back in. He puts on he preps again and does the procedure over again. All right, let's take a break.